Hello everyone, I am Dr. Klein from The Fix. Today we'll be talking about forced closure of the sacroiliac joint. So the sacroiliac, it is the keystone of our foundation. Kind of literally. Talk about the pelvis structure being your foundation, your hips. Sacrum's right there in the middle. It's tied together with lots of muscles. So I gotta think beyond the joint today, and we're gonna show you. Let me just read my bullet points here. There's a complex array of muscular and ligamentous structures that help support closure of the pelvic bones on the sacrum there. Give it a little hug like those arrows showed on the last slide. So nutation and counter-nutation of the sacrum, that's just its flexion extension, if you will, relative to the pelvis can cause not only pain but dysfunction that affects our entire structure. It doesn't have to move a lot to cause a lot of problems. The more we just throw our center of gravity off just a little bit, leads to the joints becoming hardening and stiffing and muscular imbalance taking over, which neurological stress. And what is even more concerning is how slow dysfunction of the pelvic structure can occur over decades without pain. Pain is the tip of the iceberg. So with the typical chiropractor saying to point out that pain is the tip of the iceberg. We say it all the time, I've been in the office. A lot of people don't have pain, and we'll take their x-ray and there'll be lots of degenerative processes taking place, and they don't actually feel it in that area at all, or if it's very minimal, or they have some sort of radiculopathy, or the pain's in the knee or something like that. When speaking of the sacroiliac joint, it's best to describe it as a glacial shelf hidden beneath the water, and sailor, it's going to sink your boat before you knew what happened. Sorry, I had to get a little dramatic, but it's important. When we actually see a little cap of ice above the water, we tend to ignore it as a nuisance. But the SI joint is such a stable structure and protected by so many muscular slings that if you feel the slightest discomfort there, we can safely assume there is imbalance in some of the most important muscles in the body. And we will look at those muscles. So when your foundation has got a hole in it, plugging it with passive treatments will only do so much. Like, well, Dr. Klein, aren't you throwing yourself under the bus a little bit there? As a chiropractor, don't you do passive treatments? Yes, I do. Yes, I do, and that's why I would get very frustrated with people when they're not taking care of themselves, because I feel like I'm doing a lot of work to remove restriction, and you're allowing the restriction just to come back. It's like I'm trying to paint a nice picture, and you're taking it home and rubbing sandpaper over it. All right, you have to work with me. Chiropractic is a tool, just like the other modalities are tools. They're not going to do all the work for you. Only you can train instability away by strengthening what's weak. I can't strengthen your muscles for you. I wish I could. I would do it. So the core and the keystone connection. Everyone's like, foundation training. It's for your core, right? It's for your whole body. That's why I highly suggest it for your neck and for your shoulders and other things. And I feel like I've had these conversations over and over again. People are like, isn't it just for your core? I have neck pain. What am I supposed to do for my neck pain? This is for your neck pain. Same with strength training. You're not like saying a deadlift is just for your hips. It really works your whole body. It's these whole body movements, underweight, that increases your load tolerance. That's what's so magical about it. It's working your whole body as one. You're training, essentially training your body to move better in life, because we have so many comforts that leads to curses. We've forgotten how to hinge and squat. And I saw a funny meme the other day. It's like, if only people learned to squat to depth, then our society would look like this utopian, beautiful universe. Then if it looked utopian and flat, then we wouldn't be challenging our hips, because that's our problem anyways. Everything's flat. Flat, and shoes, and sitting, technology. So I'm kneeling. Challenge it. All right, so the obliques, your lats, your spinal erectors, and your thoracolumbar fascia, which is very important. We'll look at that. Fascia are all bands that wrap the sacroiliac joints or use long levers to hold it in place. See a little diagram here. We have the form closure, which is kind of opening up of these sacroiliac joints. And there's kind of like a deeper SI joint and a more synovial. So you'll have almost like the synchondrosis in your skull, similar to the lower joint, and then more synovial joints. That's what you'll feel pop sometimes, especially if you're the chiropractor. Is that synovial joint that's moving. So, but ultimately, not a lot of motion, but we force a lot of motion in the sacroiliac joint. I'm not saying it can't be closed down, and that can't be a problem either, especially on one side or the other. But forced closure tends to be missing, especially with our hinging motions, our squatting motions, our bending motions, we're robbing motion. Even in yoga, we're robbing motion from the sacroiliac joint instead of training the hips to do it. Nothing new if you've been to foundation training class. This is what I say all the time. But now we're looking at why and how. So these sling-like muscle groups contribute to forced closure of the SI joint to help support the joint tissue and ligaments. So when we feel pain in the SI joint, it is more likely that the tendons of these muscles are irritated or have tears. So I do various tests when somebody comes in. I lay them down. I'm checking to see, is this a facet joint? Is this an actual sacroiliac joint sprain? And sometimes they're fine with the test, but they have a lot of pain. They might even have radiculopathy. But it might not be the discs, essentially, or the joints of the spine. It could be just all these tendons that are so damaged and inflamed. If there's inflammation, there's injury. If there's pain, there's injury. And we just have to learn to accept that. We're like, and they're like, Dr. Klein, I understand if there's pain, there's injury. But you really don't. And you don't treat it that way. You just ignore it and you keep pushing through it. There's pain, there's injury, there's imbalance, there's a problem. It's taken years and years to get there. We have to start changing how we're moving. We have to look at things new. We can't ignore. So tendon pathology, and you can write novels on this stuff. Well, we'll give it a little glance today. So a reactive tendon, which is not rehabbed, would become degenerative over time and leave the joint tissue to battle the imbalance. Reactive tendon means there is probably some pain, maybe not. It might just be mechanically deaf or not moving well, or not moving very well. Doesn't necessarily have to be pain, but there could be just some slight pain. But it's getting there, right? It's becoming degenerative. So collagen tissue will form inside the tendons, and the tensile strength is lost, as well its springing capacity. Tendons are part of the muscle where they attach to the bone, so they should kind of react. They have lots of nerves in there that interact with the brain and how we're moving. So if the tendon is not springing and moving like it should, it's just like it's made of hard plastic. It's stopped working. It's become rigid. And there'll be good fibers around the rigid areas, almost like little balls of Play-Doh are stuck inside your tendons and they just don't react as they should. So then when they don't do that, other things get damaged, including the joints. So we can have these degenerative processes take place in tendons without any pain until the tendon ruptures without even any really cause. You hear this all the time. It's like, got up, just walk, and my Achilles tendon just snapped and pulled off the bone. You hear this all the time, especially with lower back injuries and sacroiliac injuries. I turn funny. I didn't do anything. I've been doing what you say, doc. I've been doing the foundation training. And I'm glad you're doing the videos. Come to class, make sure you're doing it right.
So we have a couple bands of muscle. So the longitudinal one runs all the way to the skull. It attaches into this fascia called the thoracolumbar fascia. So that, if you look on the inside here where all these grooves are, those are all attachment points for that fascia.
Oh, all right.
So it covers your sacrum. And that's what will help us close. So sometimes just lifting helps close. Another thing that helps close, it might be part of the problem with the lat muscles there, since they attach on the inner side of the shoulder, run along the ribs, they attach, their tendon comes in, joins to that fascia as well. So that can close the opposite side, and that joins with the glute max and even into the hamstring, attached to the hip. So you have this oblique sling, and then we have the same thing over there. So if they're both working well, then they both help close the joint, but sometimes one is tighter than the other and one's weaker, so we'll have one joint that's closed and then another one that is opened up too much. And usually it's the open one that you'll notice is harder. Like if this is opened up this way, this usually tends to turn that way. Or this is the cause, and it's so restricted that this has to generate more motion to make up for the lack of motion here. So if you're noticing turning right in or left in when we're doing that little trick, so I'll run that really quick, is just...
that's my job there, is to try to really help you make sure you got the sacroiliac joint working right. It's closed, you're motioning from the hips, not your low back. So the next few slides, we'll look at what muscles support stability of the SI joint. Pictures! All right, so here's Phil, and we'll pull out Phil for the demonstrations and some of the live videos, and I can see that as I've pulled this from one computer to another, the pictures are covering some of my font, but that's okay. I will get through it. Longitudinal sling. So the longitudinal sling, we've taken Phil here, we've taken the TheraBand, we've just kind of covered that particular area. So we have the sacrotuberous ligament kind of connecting here to the thoracolumbar fascia, and then we have our spinal erectors, which are the big ones. There's 3 different bands of those, and we will look at those. The I love spines, if you want to remember, if you're studying for your boards. So multifidus here is the deeper layer, so that'd be the spinalis layer, which is formed of the transversal spinalis muscles, which are the deep grooving muscles here in these on either side of the spinous process. And then we'll have the iliocostalis, which is the outer layer, and then longissimus, and then spinalis, which is more central. So the different layers, and the thoracolumbar fascia is not just one big band of fascia. Some people think there's 2 or 3 layers of this fascia, which kind of separates. So you'd have this longitudinal sling. You could have thoracolumbar fascia, which are lats attached to. If you ever look at just some plain anatomy, I think we'll look at the lat here in a second. Just you have the lats coming down, its tendon inserting into the thoracolumbar fascia, which creates this triangle shape around the sacrum and the SI joint, just something that would hold it together. So very stable joints, lots of muscle going in there, and we'll look at even more here in a second. But when we have pain in either of these SI joints, we're assuming, okay, now the lat and these muscles, the posterior chain is failing. Let me read my slides before I move on here. So some call this the posterior chain. I just did. Its engagement helps resist the posterior pelvic tilt. So that's the tucking of the pelvis, or the butt wink, we call it sometimes when you're doing your squatting really deep, and the pelvis will tilt underneath. Not necessarily a bad thing, but if you've got some sacroiliac joint problems, or you're always relying on that tilt, or you're really just kind of rebounding out of your squats with heavy weight, this can lead to pelvic floor issues and ultimately not getting the actual mobility in the hip that we truly need and desire. The posterior pelvic tilt that often likes to pull the SI joints apart. So that's the problem with posterior pelvic tilt, is it will try to pry these SI joints into more form closure instead of force closure. So we need to inflate, I don't know exactly what I'm trying to say here, but we need to inflate the thoracolumbar area to prevent this, especially when you're doing a squat. These people like kind of breathe in big and heavy, they'll expand the diaphragm in all different directions, not just forward, but wide and back. That's it. That'll stretch, and that's the same position you'll notice we'll do in foundation training with measuring stick hands, is we're inflating the thoracolumbar area. And you can really feel it. Once you kind of, we'll look at the pictures, you can like, oh yeah, that's what I feel when I'm doing that. That's setting you up for your heavy lifts. All right, so multifidus attaching the sacrum and ascending the whole spine. That's a big part of that longitudinal sling. And we have the deep layer of the thoracolumbar fascia. Like I said, there's multiple layers of it. And the long head of the biceps femoris attaching to the sacrotuberous ligament. So we'll have a better picture of that. But pretty much your sit bone, which you might be sitting on right now, that's where your sacrotuberous attaches. And you can think of that just kind of like an extension of your hamstrings. Right? Hamstring muscles, well, 3 of them attach here to the sacrotuberous. You have your biceps femoris as well, the short head, which is more lower distal shaft of the femur, which goes down to the knee, which does not come up here, but big old band kind of joins the sacrotuberous. We got the glute, and then we're going to get into this oblique sling, the posterior oblique sling next here. So thank you, Phil, for and I also like this down view. You kind of see the inside the joints here, and look at these grooves. So there's lots of muscles that will attach here. Anytime they got like a rough area in a bone, okay, that's where a tendon or a ligament is attaching. So here we probably got obliques coming in, this thoracolumbar fascia is all connecting here on the SI joint. So you can see how it would help to close this down if there's gapping, and if I'm feeling, touching here, there's sprain here, or even as we get into the lower lumbar spine, we could have these facet joints, which allow for your flexion, extension, and a little bit of rotation in your spine. It can be damaged by failure of the muscular structure. So the TLF, the thoracolumbar fascia. So you can see the lat here forming its tendon forms in, and we've got this big triangle. That's right where your tailbone is, where your SI joints are. And it's just one layer what we're seeing, right? It's kind of even the traps come down, they form into that, and then we'd have a lot of those bands of muscles that we just talked about deeper to this. So injury in this large sheath of tendon and fascia, if muscle balance is great enough or has been present for a long enough time. So we have 2 or 3 layers that separate the back muscles. It serves as a hub that intersects into the sacroiliac joint and covers the sacrum. So the deeper layer separates the QL, quadratus lumborum, and the psoas. We're always talking about the psoas in foundation training. Very important muscle. Probably should talk about the QL more. It's also very important. But it separates from the spinal rector muscles, and then there's an outer layer which separates that from the lats, right? Some of this information I'm pulling from this link here, so you can go there. So, spreading it before we lift, or even just bending. You don't have to do it all the time, just preparing. The more you do it and train your body to do it, you'll do it unconsciously. And you'll protect your back. You won't always be bending from your lower spine all the time. All right, so let's look at kind of what we already did. We get this anterior border of the ilium, which means it's just more forward. And we have all these attachments. So already kind of named those. We'll just move on, just giving you another little picture there. There we go, posterior oblique sling. So we got Phil over here. Took a little TheraBand. If you look at this trochanter bone, we can see it over here. It's your trochanter. What attaches there? Well, lots of things, but the big one is our gluteus maximus, right? So that comes there, and then what we mentioned before, the biceps femoris kind of forming into our sacrotuberous ligament, which is just often very tight, either on both sides or one side of people. If I'm ever digging in this lower area and you're like, it's kind of close to things, Dr. Klein, why does that hurt so much? Most people aren't like necessarily shocked, just like, why is that sore? Why is he in there? I'm really sorry about this font here. I should have checked some of this. Every time you transfer a PowerPoint to another computer, just the pictures are off. I'm surprised the arrows are still pointing relatively to the right areas. Lat muscle, we just showed that thoracolumbar fascia and how the lat comes up, really connecting the hip to the shoulder. So we have this sling, this connection. I could even think about the hamstring going down even farther into the knee. It's just a longer lever, this big X that's coming in. If you've ever done the 8-point plank, I'm always telling you to think of a big X. This X pulling into your abdomen, not lifting yourself from the ground, but squeezing the ground away. You're essentially activating this X to work. So you might notice one side or the other, a little shaky, a little harder. Sometimes when you're engaging something, it just feels like something's out of place, and it probably is. Your bones and your ribs aren't lined up as they should be, but we can pull them back into place doing this. So not just your chiropractor putting them back into place, because just put it back into place. We haven't created the strength and stability for it to remain there. Big X intersects the tailbone, hugging those iliac bones to the sacrum. I'm going to guess that says. So we get the arrows pointing to those muscles. So that's our posterior oblique sling. And then we have the anterior oblique sling. So that's just on the front. And this is probably what most people think of. Core, right? Work your core. You can work on your core. I think I rant a little bit here, so let's read this. A strong core means a strong back. Yes. So I've known many supporting a six-pack walk in the office that have debilitating back pain. So just don't think, man, strong core, strong back. I'm going to do lots of crunches. And it's the same problem people have with like, I'm overweight, I'm obese, I need to just hit the elliptical until I die. Or walk. Walking can be just as devastating as lifting heavy in the strength training. A lot of times it's not your heavy lifts that injure you, it's the little things that injure you over time, right? If you're not walking right, you're not using your hips, and your SI joints are doing all that motion, they're not supported, they're not closed down, that's injury over time. It's little micro traumas. So don't lie to yourself. You gotta train yourself how to move. And a lot of times lifting, the heavy lifts especially, force you to have good posture. Put weight on you, your body automatically inflates. You automatically lift up against that weight. Your feet engage, your hips engage, everything engages. You're just like, oh, there's something here. You got this neurological stimulus. There's this weight on you, and your body's resisting it. It's expanding. Your breath is going to be different. How you move is going to be very careful and slow because you're suddenly aware. If you're just in there, got light weight, and you're doing deadlifts, just like 40 kilograms on each side, and it's super light. You might be more likely to damage yourself there because you're not attacking it as you should be. The more heavier we attack things, the more stability will be maintained. And I'm not saying just go lift heavy on your first day. I mean, you still have to train. And that's what's great about foundation training is you're learning to find resistance inside your body, even without weight.
Think big and tall. Let's get that longitudinal sling working for us. Big inhale, we're just inflating. Think a little wide too, that'll hit the lats. Make sure you have a little bend in your knees. Knees shouldn't be locked out. And then dorsiflex, 1 foot. And you should feel a lot of engagement. The knee's gonna wanna straighten out, don't let it. Big and tall, you're gonna pull that foot up really hard. It's like someone's got a band and they're holding your toes down. It should feel like that. So you should feel a lot of fascial tension right there. Let's take our thumb, so right foot's up, right hand back, put that thumb right there, hold that joint down, just like that. So I'm holding that in, knee bending, and I'm gonna turn at the hip joint, so you should feel this kind of, you might even feel that muscle stretch from here to here, just opening up. And let's repeat that on the other side. So we'll close this one down. I guess you can hold both if you want to.
It's lower than I thought it was.
Right there. And then turn in. So one way to find it is if you're doing your measuring sticks, you're feeling this guy, the ASIS. So if you just travel along your crest here, you'll come to a dimple and then a little bump. That's this guy.
Oh, that's your bump.
So PSIS, ASIS. So pinkies should be here, right? Decompressing, so you can just, okay, where is that? Oh, there it is. So all that fascia is going to be inside that bump. So if this is pulling apart, it's stretching. It's a lot of injury you have is here. So think about that fascia, it's supposed to guard all this, but if we're always bending from this area, especially if we got weight, or even without weight, just bending, right? Irritates. So foundation training is about all our typical movements. You really only need a few good movements to really train yourself. But this is like the starting point of our movements. Breathing and bending, right? If you're gonna do a squat, we kind of want to have these principles first. Because if we're just gonna start stretching, I'm like, okay, I'm gonna squat, and the first thing I do is stretch that thoracolumbar fascia, and I start my motion there. That's bad.
A lot of times I like people to imagine tension, imagine weight. And that helps them. And then you can go out, start throwing kettlebells around. So we can't just crunch our way out of pain. We need to train these muscles to work in a decompressed state. Decompressed, that's load tolerance. Same idea. We're expanding that thoracolumbar fascia. So the position of the spine and hips matter. To lock or to unlock. It is common for one sacroiliac joint to be closed and the other to be open. And we find this with rotational distortions and muscular imbalance in the slings we just mentioned. So both can be unlocked or both can be closed, causing different problems. We are either looking at a hypermobility with posterior pelvic tilt or a restriction in the anterior pelvic tilt state. And I am a person that gets very frustrated with pelvic tilt. And it's something I kind of, if we go way back, like 4 years, 5 years when I first started doing videos, it's all about pelvic tilt. And people get so focused on, like, I know I'm posterior pelvic tilt, I have to fix this. Or I know I'm anterior pelvic tilt. So if you just start decompressing, your tilt tends to find its way out of there. And if anything, if you really have a tilt problem, I'll address it after you're decompressed, because you always want to address it in a decompressed state. Because if you're just tilting and then trying to decompress, it doesn't work. And often, especially with posterior pelvic tilt, the body will adapt. It does this sway back thing, which we'll look at. in a second here. But it will tilt posterior, which is, if you're in a really decompressed state in your posterior pelvic tilt, that's kind of where you should be, where your weight's back. But this is very uncomfortable. So people let their hips slide forward, and it'll look to your average observer that you have anterior pelvic tilt, when no, you actually have very, very shortened hamstrings, and you're in posterior pelvic tilt, and you probably have sacroiliac joint instability, which leads to instability in the rest of your structures. So arthritic changes can occur from either too much force closure or form closure if stability is not achieved. Here we go, center of gravity. So this is the first one I was talking about, the posterior pelvic tilt. She doesn't want to have this super tucked and engaged glutes while her weight's back in her heels. It's hard. The body doesn't like things that are hard. It likes to use the spine to bend and extend and be in a compressed state because it's easier. You don't have to use as much muscle. But breathing's not so good here, right? Shoulders are really turned in, and we got the reverse curve going on in the neck. That's why I say, how could foundation training affect your neck? How could this not? How could this not affect your neck? If your hips aren't right, how's your neck supposed to be happy? A lot of people do this too, though. I call this the runway models. They're trying to get back there, and they're trying to fix a neck problem. Gonna cause that problem there. And it looks like she's got some problems of her own too. It's funny when people have like a certain posture type and they're trying to show another posture type. Good example, you can see it. But when we get her into her state here with the lordosis, a lot of people think this is lordosis because you look at the spine. It's going to look similar, but it's going to be more like an S shape, where this is going to be an increased C shape. It should be a subtle C shape anyways in the lumbar spine. But even in her neck here, her neck curve is still flat and back. Both of these are really squeezing the rhomboids and really driving the head back. So neither of these are correct posture anyways. They're both bad. So sometimes they'll call this anterior pelvic tilt or athletic hip. So more quad dominance, more hamstring dominance, but even that is just painting too simple of a picture. And if we look at the thoracolumbar fascia in either of these states, if we got our arms out of the way, it's shortened, it's compressed. And everyone likes to be expanded in the front because that's where the cartilage is in our ribs, so we can breathe easier, but that kind of closes down the back of the spine. Closes down all these, it tightens all that area. So anterior pelvic tilt will tend to have closure, but we can have degeneration there if it's closed or closed too much on one side. So too much of a good thing, right? Is also a problem. So as anterior pelvic tilt increases, the center of gravity shifts forward. And we almost said the same thing here. Shifting forward or backwards, depending on how far they go. Getting some of the weight out of the toes and into the heels can effectively pull the pelvis back beneath the spine as the thoracolumbar fascia becomes engaged, so the sacrum moves with the pelvic structure without nutation. And we'll dig into that a little bit more, definitely show that in class. So posterior pelvic tilt will force a swing of the pelvic structures forward. So that's the first picture there. Essentially, we're expanding the back, we're expanding the sides, that rib cage, and our lower spine too, because there's no ribs down low in the lumbar spine. It's a kind of an unprotected area, so we have lots of muscles to do it because we don't have a lot of joints to rely on. So we need to strengthen the muscles to do that work instead of just relying on a few lumbar joints and discs to do everything for us, because eventually they will fail. And there they are, those bottom three, L3, L4, L5, sacrum. So we have our psoas. I know, lovely drawings by Dr. Klein. Not so great, but I like to draw. It helps me learn. And we have iliacus. So iliacus is sitting on that ilium bone. And both of these muscles, they form a tendon which attaches to that lesser trochanter. So if the lumbar spine and the hips are not moving and we're thinking like an isometric engagement, that's going to help force closure. Because then the spine's not really working, and then these muscles together act like a bowstring. So it tightens and the spine itself shifts back. The whole structure comes back. And that pulls the weight into the heels, forces the feet and your arches to activate for once in your life, because we just lack our feet have so many nerve fibers. They're like our hands. Just sensation is such a high thing here, but we just it's like wearing really thick gloves all the time. It's just going to affect your hands. And you're not going to be able to move as well. You're not going to be able to grip and grab as well. And that's kind of what we're doing to our feet. Put them in these tight shoes. And we walk on flat, hard surfaces all day long. We don't have gravel and sand and grass to grip and grab like we should. So then our hips fail. And then our SI joints just are forced to do all the motion. Lumbar joints forced to do all the motion. Hips are not. So Iliopsoas, here it's called the major stabilizer of the lumbopelvic region. That bowstring effect. It's supposed to hold it all together.
That's going to get irritated over time. So we want to keep this kind of locked down and protected when we're doing any heavy lifting.
Oh, no.
That making any sense there? Next, we have our oblique slings in the front. So the anterior ones, creating a big X. Again, they attach. So we have the transverse abdominis, comes out from the side here, attaches to that thoracolumbar fascia, goes around to the front, and our obliques, which all create a big little X right in the middle there. So our linea alba all comes in. So that's why we're kind of engaging the abs, even the psoas, really deep to that. It's all part of that. Going to help us close down.
So can you strengthen these long ones in the back that you're talking about?
Yeah, the obliques back here.
Yeah.
And some of us, like you are not lat dominant, but you are. So you have strong lats. So it pulls you here, and it turns your shoulders in. You're a bit of the opposite. So you probably have very weak lats.
Correct.
So you want to really engage those lats, pull them
Really
big
think
and
about-
broad. Tara and I, we're used to it. We already like,
Someone tells me to stand up straight. I'm like, all right.
yeah, we do this.
And you do that.
Like this is standing up straight to us. Just those muscles they're so used to it. And it actually makes our shoulders worse, so they turn in even more. It looks like they're turning out, but they're actually rotating in,
That's probably why mine
and the shoulder blades are coming back.
Okay, that makes sense.
So maybe good for you to even start up top, thinking about maybe a little bit of that, and then engage. For Tara and I, we want to think almost like what they teach deadlifters to do. A lot of deadlifters will kind of pull their hips back, and they'll think about their mid-back lengthening and then flexing a little bit. And it's kind of flexing more from here. So think flexion, we're like, oh, you're rounded, but it's only really rounded from like T1 to T5. Those are the ones that are kind of inflection. Like if my head's forward, those are inflection. But they're kind of from 6 down to 12, they're all an extension.
I think that the best is for me to start up here, like you said, make sure my neck is.
Yeah,
Like,
you get your neck.
You did that.
Since that longitudinal one's a big one, it's a big player.
Okay.
Because there's 3 big muscles there. You have your iliocostalis, your longissimus, and then the multifidus, the spinalis, the one we always talk about. And they just go all the way up to the skull. So you remember, I love spines. Iliocostalis, longissimus, spinalis. That's how you remember. But since they go all the way up, they're very powerful. So when we're doing this, the posterior chain is pulling on those, and that pulls on this fascia, closes it down. So just from the head. So even if you just thought about the skull and lifting, I feel that change my whole body, change my whole
That helps me
posture.
a lot.
But let's go back to that deadlifting idea.
Okay.
So even, because our tendency is, oh, we're going to engage, and we kind of arch. So if I kind of just get a little tight here, and I'm flexing from here, and then I can either lengthen out of that, or I can kind of flex and lengthen at the same time, which is kind of the best of both worlds. Because they want, when they're lifting, they want to be kind of here, because that's protecting their spine. It feels like terrible posture to me. It's like, this is not good posture. I feel like, but I feel so much more tension. It's actually going to protect my joints and my discs. Where here, it looks like probably decent posture, but I've just further extended these, I've created further flexion here, and it's just compression. Compression causes depression.
Oh, yeah.
For your chiropractor.
Okay, Dr. Seuss.
And so thinking of those slings,
Okay.
maybe a good idea, of good visual, because we're engaging a lot of stuff to try to help. And nothing's perfectly isolated when we talk about this stuff. We want isolated motion, but there's a lot of different muscles working. Got a lot of stability muscles working. So if we have like a little sprain here, it's not always in the joint either. I will say like, well, that's an SI joint sprain, but it's probably just tears in this thoracolumbar fascia. So you got a tear in there that's telling you your hips aren't working right, you're not breathing right. That's the two things we need to work on. Breathing, then working on hinging, then we can start adding weight.
Protect it. When the femur and lumbar spine are fixed, they don't move during iliopsoas activation. So if you think about like iliopsoas can kind of raise if you bring your knee up to 90 degrees and go a little bit higher, and then it's going to activate it. And that's people like, well, that's majorly what it's for. No, that's not its whole job. It's like a rotator cuff. You can think about it like a giant rotator cuff. Its job is to hold the hips into the socket, just like the rotator cuff holds your shoulder in the socket. So it's not always protracting or shifting in a lot of internal external rotation. It's being held tight. We call that proximal strength in foundation training. Proximal strength, distal range of motion. Keeping the shoulders close to the body, keeping the hips close to the body, trying to move in that state, in that decompressed state. So the iliac portion will contribute to a locking of the SI joints as long as the pelvis is not allowed to tilt. So sometimes we'll activate these muscles we're trying to get in our decompressed stance, and we'll just tilt or open up the SI joints. So we want to close them down, hold them closed, and then activate these muscles. And that's when we get the structural joint change. Degeneration. So we can have sclerosis from a locked and chronic forced closure on one side. We could say the right's really closed, and sometimes the left is opened. So we'll see the left is got a posterior, externally rotated ilium, and be an anterior, internally rotated on the right. So they're shifting, and that causes the spiraling of the spine. And sometimes that's even from the neck. The neck is out of place, then chicken or egg, what's causing it? So hypermobility leading to a sprain, strain injuries. That is it joint or muscle that's being injured that occur often or fail to heal. So we have this injury that keeps coming back over and over and over again, or just never really leaves. So, it kind of feels better, and it comes back. It's like the same side over and over again. Or it's this big injury, and it's usually not the case. It's like, man, I got hit by a car, and I got this bad injury. And sometimes there's already an injury there, and then you have this impact force, and it was already set up to be injured. That is also possible. So immobile joints tend not to bother us. Immobiles, not moving very much. They tend not to bother us, but can cause issues elsewhere. So this is the whole two frames of mind. When I first started going to chiropractic school, and I was first a chiropractor, I was like, yeah, the restricted joints, they don't move. My job is to move them, and that will help the instability elsewhere in the body. And that probably does happen, but not as much as I would like or have learned that it happens. So I tend to blame instability. There's a joint that's unstable. It's got too much motion, and that's causing restriction on the other side. But it can definitely work both ways, and they both play off each other. So we may even be able to blame a restricted SI joint on the unstable one, right? So kind of reverse psychology there. So the body will respond to an unstable joint after a prolonged period of time by adding cross-fiber adhesions, which are rigid, non-spring-like tissues. Kind of talked about these before, like these little donut hole shapes in the tendons that result in very stiff mechanics. Like I said, the idea is like you're mechanically deaf. You can't feel, or to be deaf isn't the right word, but you can't feel the vibrations, and your brain isn't connected to its proprioceptive mechanisms as it should be. And another word for this is mechanoreception. So not just pain, especially some of the smaller muscles in the body have very, very high levels of mechanoreception, but not so much nociception, which is pain.
Are we going to go out?
Yeah, so we'll go about shoulder width apart. And we don't have to internally rotate a lot. Let's just think more about, because the more we internally rotate, the more the SI joint wants to help out. So sometimes even a little pointed out is good. And anytime I dorsiflex, I kind of peel the foot down and grip. Down and grip. Just like the warm-up we were doing. Sometimes if you get back too far, that's when you lose the grip because the weight starts going in the heels. And that's usually when the knees start coming back. So I want to think about the hips starting our squat, but then we're going to use our knees and the rest of our body. And pretend like you got some weight. So what we're going to do is get big and tall. We're going to take our thumbs, maybe start with just a slight hip hugger, just a little squeeze. Lengthen that thoracic spine, maybe curl it in a little bit, just so you can get some better engagement. Flip the hands around, trace up right to our collarbones, and then pull the elbows in really tight, close to our body. So I got my thumbs right below my collarbones. I'm just going to pretend like I'm holding the bar here.
Okay.
I'm first going to do a little hinge. I'm squeezing, pulling down, and then we're going to squat into it. And then push the knees out as you drive them. Let's do that again. Little hinge. Drop the butt, squat. Try to keep your eyes forward, don't look at the ground. And then power out of that. And just think about the feet gripping, sort of hinging, squatting. And then push out. Good. Let's hinge. We're going to take our left leg, we're going to bring it behind us. Kind of really long. What am I hitting? Kettlebell. Go long wing. Scoop forward. So we're doing woodpecker first. We're going to get the hip to work. Pull your right hip behind you. And now I want you to push off the back foot. Let that knee travel forward a little bit. And then push out of the arch, come back up. So the trick is to have a nice arch. You're hinging, allows the arch to grip a little bit because you're taking the weight out of the foot. Not locking the knee out. And then as we come forward, we kind of keep resisting. Let that knee travel a little bit. You might feel it stick on your ankle, that's good. And push out of it. Hinge. Knee bend, hinge, knee bend. So it kind of goes from quad with the knee bent, then using the hamstring, getting that tension there.
Oh.
Let's go back to long wing. Slide up. Squeezing those elbows in just helps keep our spine honest. Step back into the hinge. Switch legs. Step back. Nice and long. Long wing again. Scoop up. Pull that hip behind us as we reach. Then let it bend. And get a lot farther with the left. Hinge back. So it's okay to let the knee go over the toe as long as we've incorporated the hip to work. So I'm almost hinging before I start, and then letting that come forward. Long wing. Thumbs under the collarbones, squeeze those elbows in tight, get your neck long. Step the right leg back, stay in the hinge. Push out of that. All right, shake it off. Oh. So even when we first start, sometimes we're like, step back, we already arch the back. Just a little strain on there because you're bending there at the spine. So setting ourselves up and we're hinging. Got the SI joints closed down, and then I'm stepping into that. A lot better way to do it.
Oh, yeah.
And then I'm thinking about hinging. Even if I cut my hands here, just watch my hip. Pulling that hip back, feeling that hamstring. And then I'm letting the knee come forward. Hinge maybe a little bit more. Hinge a little more. And you can go super long with this if you want. You can get all the way down here, or you can raise your foot up on something. Hinging, letting that knee travel. So let's try some of this ideas with some weights. We got some kettlebells. Who wants the 35? You can split between this one.
Okay.
I will demo. So weight is our friend. It can help us squat better. So another position that looks really similar to this is holding a kettlebell right here. So I get my kettlebell up. Let's call it a goblet squat. We hinge just a little bit just to start the motion at the hips. Then I'm keeping my chest up. Sometimes the kettlebell wants to kind of drift out. Keep it close to your body. That'll keep your spine nice and long. And then I like to think of pressing out of here, going overhead. Squatting down slowly. Let's try some of those. So we'll come down, do a 1 1/4 squat. So we'll squat, come out a little bit, maybe go a little deeper than you were before, push through the ground. And if you think about throwing the weight overhead, that's when your legs are going to be forced to drive the weight up. A lot of times with kettlebells, like swings, a lot of people just kind of shoulder it.
Ew.
Instead of using your legs, or using our legs to come up and down. All right. You got this, Heather. Who wants the big one?
Very intimidating.
Are you that strong?
She's got it.
I know my wrist on there.
I'm more serious.
Sometimes when it's super light, you just cheat. When it's heavy, you're actually a little more guarded. You'll be a little more careful.
No, Steve.
Sometimes it's light. Get that close to your chest.
Oh.
Remember, we're zipped up here, right?
Or zipped.
Zipped up. Keep that in close contact. Make sure it's touching your sternum the whole time, because it's going to want to drift out. Don't let it. Let the hips come behind you, and they have to, which is good. A lot of us, if we do like this, like the sissy squat, where the heels come up and the hips aren't doing anything, and the pelvis is tucking, a little butt wink. This weight will help you because I got the weight here. If my weight's here, I'll go forward. So I kind of have to get the weight back. So that's why having some weight is good.
Oh, it's better to.
And if you can,
I feel like going out is better.
if you fail, even if you're just like, okay, that's still good. You're still forcing because you're going to start down here and you think, I'm going to power up. I really have to drive up. Get that weight overhead.
This will help me get the weight in my butt.
Throw it overhead.
Oh.
Call that a squat thrust.
That'd be good practice. 15 pounds? I'll get one of these squats. Okay.
Yeah,
You
yeah.
can do this when you throw it to the ceiling.
That's right. You're so strong. Watch the feet. Keep them gripping the ground. Forget about the weights. Let's just decompress. Set the feet. Let's get a nice grip going on the feet. So a little knee bend, dorsiflex, peel that foot down, grab. And when we're squatting, it's okay at the bottom to let the knees pass the toes as long as your heel is down.
Okay.
The only reason we say don't let your knees pass your toes is because most people tend to do that.
Oh, okay.
So maybe the better way to say it is keep your heels down.
Right.
Especially as we get deeper, we want that ankle mobility. Like if you're like me and they're terrible, something to really work on. So that's good.
Is that good?
Yeah. Just remember, we're here zipping.
Oops.
It's going to make it a lot harder.
That makes it a lot harder.
The reason for that is it just helps lengthen. We're tracing, right? And then we're locking in that length in that spine. So it's going to simulate having some weight. And those hands can't counterbalance. Because a lot of us want to kind of hinge. we're doing a little hinge, but then we're squatting. Maybe even stop. Push down. Squeeze those elbows in. Give me 10. Let's see.
Is this supposed to make it transfer to the knees?
Shouldn't feel in the knees.
Okay, then I can't go that far. Okay.
Sometimes you have too much ankle mobility. It's a thing.
That's probably what. Okay.
I can even see your knees started the motion. It's like you're here and your knees, just because you have great ankle mobility and I don't.
Because of my
Because you're just a different posture type.
So I have to really think.
So maybe you should even arch a little bit. Pull the hips back. Make sure your feet are gripping. Make sure the hips, you should feel the pressure in your hips. Pressure out of the knees. So my center of gravity is here. That's why I don't want you reaching. As soon as you reach, shifts into the knees.
Yeah, that's bad.
Did you feel it with the weight in the
Better
knees?
with the weight.
You didn't feel it?
It helps, I think.
The
because
weight is your friend.
weight is. I have a couple.
Feel your belly. Think about your diaphragm. Spreading wide, spreading back. Even a little forward's okay. One thing, I just don't want the diaphragm going here. But it is kind of, I am inflating a little bit in the front. Because that's going to protect the spine here, because it's got no ribs. It can protect this fascia.
This is a really good one.
All right, let me see that thing.
Yeah.
So we'll take it behind the head. We're going to open up. So I got the handle just resting right here, below the occiput. Maybe go a little wider.
Be careful.
Let's change.
Yeah.
Let's put it back there. It wasn't so
I got
bad.
it.
You guys need more of these.
Save my friend.
Yeah, this one's like.
So I just like that right here, so I got something to press against. I used to do it back here because it kind of feels good, but I like it, the handle behind my skull. So as I hinge, my head is something to lift up against. Just keeps your neck a little honest. I'm squeezing my elbows away from each other. And then we can transition to that same exercise we did before, reaching long, maybe hinge a little bit, then let that knee come out and back. And then come back into the hinge. Step the right leg way back. Hinge, forward, and back. Forward, and back. Forward, and back. The trick is not letting the pelvis kind of do that trick. And that's one thing where the weight will actually help you be a little honest.
You should try this one. I was holding it wrong at first, so hold it right. Wait, this?
Handles on the side, just like this.
Oh, and that goes in the back. Okay.
Oh.
I was holding the top part of it.
Handle right underneath the skull, yeah. There. Then go wide,
Oh, this feels good.
then hinge.
Weird.
Help me not look down.
Hinge, hinge, hinge.
Feel more weight.
And then once you got that good hamstring tension, you'll step back with the left.
Step with the right.
And you can go really long if you want to. And then we're just pushing forward that knee, pushing out. We're just in a constant hinge here. The thing with the trick with the knee is the knee wants to go, the pelvis wants to tuck with it. Keep that hip back.
Oh, right.
It's a really subtle movement, especially if you got limited ankle mobility like I do. But that weight's gonna push you a little farther. This is one it's called the cane squat. So you're just hinging down, you're gonna grab onto your toes. So
This one actually wasn't good.
I'm gonna push my toes into my fingers, stretch my hamstrings, and then you're gonna squat. Open up those hips, then hinge, and you can do that with the weight.
Do it without the heels up.
So if you got the kettlebell, I'm gonna hinge here, and then just do a little curl, and then hinge. It actually makes the movement easier for me. So it actually pushes me down into the squat a little bit more, so I get a little depth. First is here, if I'm holding there, and then squatting, that's actually, I gotta really force myself down there.
Because you're